This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
My name is Joe Sam Robinson. It's my pleasure to have with us tonight Dr. Eddie Young. Welcome, Eddie.
Thank you very much. Glad to be here.
You have a lot of titles and a lot of responsibilities in the medical world, but one of them is that you're the president of the Bibb County Medical Society. Is that correct?
That is correct.
And so how many people are members of the Bibb County Medical Society?
The Bibb County Medical Society is a little over 250 members right
yes,
now.
Right. And so you represent doctors in Bibb County and Macon and just general issues involving health care?
The Bibb County Medical Society is a component member of the Medical Association of Georgia, and it is a historical medical society well back over 100 years in our area, and is the second oldest medical society in the state after the Medical Association of Atlanta.
Is that right? So we go back a long way, and that's a lot of responsibility. Well, are the doctors restless these days, Eddie? We have a lot of changes in the healthcare system, and
the doctors are unsure.
You're unsure?
They're unsure. They're worried. They're looking to the future and seeing clouds on the horizon.
What are some things that worry physicians these days? I mean, we have all this. We've had discussions on our show about different parts of the American healthcare system, but what are your opinions? What are things that disturb doctors as they face the future?
Doctors that are aware know that now that the Accountable Care Act has been made or qualified as lawful, then they know that there's a series of timelines or trip lines that are coming in the future. Starting in 2013 through 2015, there is a series of events that will have to be put into place, or things which have to put into place, which by the year 2015, if they're not in place, will essentially impose penalties on organizations and physicians if they haven't come together to comply.
So what are some of those things that are in the hopper, if you could name a few of them?
Well, you've heard the states have to form the insurance components to allow people to come together and buy insurance. And some states can opt in, states can choose to opt in or opt out. It'll affect their Medicaid reimbursement. For physicians, ultimately, they're wanting us to be what's called vertically integrated, to mimic the banking industry. And after that, they're going to want to have us in what are called accountable care organizations.
What exactly is that, Eddie?
We're not sure. But we know that we've read it and looked for it, and I keep asking the questions. If you have an accountable care organization, which we think is going to imbue a hospital, a group of physicians practicing at that hospital, ancillary services to that hospital, such as home health services through what they call DME services, outpatient services, things like that, that those will be given a group of patients. We don't know where the patients are going to come from. We don't know how they're going to be divided up. We haven't seen the fine print.
Now, do patients have a role in this? I mean, in other words, if you show up at a healthcare institution in the future, you'll be given like a piece of chocolate cake to some organization. I mean, don't patients have a role in deciding what happens?
We don't really know. We just know that by 2015, all this is supposed to be put into place. And since everybody was waiting for the Supreme Court decision, there was a lot of twiddling of thumbs and nothing being done. The hospitals have taken the first step towards what's called the integration process, trying to upgrade their computer systems and start having the ability to electronically communicate. There's a group of physicians associated with the hospital in what's called the Central Georgia Healthcare Network, and they have put together what's called a information hub That meets one of the definitions that the HITECH Act requires. And out of that, they are laying in the processes. But as of last year, Kaiser Permanente, one of the most advanced electronic healthcare organizations in the country, was like 12 to 15 points shy of meeting the government standards for accountable care organization. So even they aren't able to be there yet.
Well, you know, theoretically, I'll play the devil's advocate here slightly.
As you do so well.
Some occasionally. But I mean, if in fact patients, we get some better, I guess, knowledge of how therapy is working, I mean, that sounds good. It's just the devil's in the detail, is it not? I mean, so if you said, well, this is the way we treated cardiac failure, and this is the results, and so therefore we might do better to try beta blockers a little sooner, or whatever comes out of the information that would be obtained. Presumably there could be some good. The question is, how difficult will it be to get that information? And once the information is obtained, will it be used in the patient's best interest?
Well, that's a very good point. I gave a talk to the incoming class of the freshman class at the medical school this morning. And one of the things I brought to their attention that their biostatistics will be very important come in the future, because the most important part of an accountable care organization is the word count. There's going to have to be, you know, a very large volume of data gathering. Then somebody has to vet the data and make sure that it's appropriately measured and accounted for. Unfortunately, hospitals are not very good at measuring things and counting things.
So this yes. That's a big deal, isn't it? I mean, one of the things that happens when we try and decide the right thing for patients is discovering the complexity of causality. What's causing a particular thing in a patient's life that's bad for them? What are the factors there, and what's the best thing to do to treat that? And it turns out to be very complicated. And I think I've heard it said in the doctor's lounge that one of the things that goes on, there are different ways that the feds rate hospitals or physicians, is they might be pretty elementary about the way they do it. There's not enough sophistication, for instance, in saying, well, this is a bad hospital, the infection rate is a high infection rate, but all the vagaries that go into patients that might be at risk to have infections are not really put in the equation. So it could be, these statistics could give a lot of false information if they're not carefully vetted. Is that fair to say?
You're exactly right. And when the federal government sets standards, the people who understand those standards and adapt to them the quickest will have the best scores the soonest.
Yes.
And so it's almost, you have to have a whole team of people trying to figure out what is it they want to measure. What do we have to do to adapt to the measurement?
Yes.
And a lot of the question is, does it actually improve care?
Yes.
And, you know, going forward, we're going to be, you asked about our doctors worried or unsure about the future. We're going to be measured on a mortality rate at the hospital. Yes. We're going to be measured on readmission rates to the hospital. That's an interesting concept, to be measured for readmission, because the presumption is that if a patient has to be readmitted, it must be the physician's fault.
Yes.
And you brought up the patients. Where do they fit into this? You know, they're an enormous part of compliance and their care. And sometimes their diseases exceed our ability and the patient's ability to do well. So having readmissions is unfortunately sometimes a fact of life.
Well, maybe we could bounce the basketball in that regard. Let's see, my old brain here is vaguely remembering something called quantum mechanics. So if you can recollect quantum mechanics,
theory,
quantum back in physics. But the idea is that a elementary particle, if you measure it, it changes. So if you, I think that's fair. So these little particles are spinning around, and once you measure, you say that's where the particle is. It's no longer there because the act of measuring changes the particle. So one of the things that happens, the unintended consequences of a lot of the changes in the American healthcare system is, I think you rightly point out, all kinds of different vagaries are going to be measured, and there'll be a vested interest in healthcare providers to conform to whatever is considered the A+ in the measurement scale. And the way the feds are putting these measurement arrangements in, there's a lot of things that are, I think, open to discussion. You mentioned hospital readmissions. So I think it's been my observation that one of the things that goes on, particularly with Medicare patients, is that the hospitals are really penalized now if there's a Medicare readmission within 30 days after
for the same diagnosis.
Well, so there's a lot of...
They don't get paid for it.
So well, not only that, but all sorts of penalties and red buttons go off. And so what's occurring is that patients are being kept an extra long time in the hospital, which is, uses an enormous amount of healthcare resources, and also the patients can be sort of kidnapped and kept in the hospital a little bit. I'm not saying that's always the case, but there is the fact that the healthcare organization in the hospital would be penalized substantially by letting, if a patient left too soon, according to these measurements.
It puts a very big pressure on the physicians, because they're sitting here on one hand being pressured by the hospital to keep the length of stay low and move patients through the system quickly, but at the same time has to be worried about readmissions. And so trying to achieve the perfect balance, the feng shui of medicine is a very difficult proposition.
Now, Eddie, have you ever had a chance to chat with any of the bureaucrats that propagate these regulations? Ever have an interchange with them?
No, and I'm still asking who wrote the Accountable Care Act. I ask that all the time.
Right.
I want to know who penned it.
Well, one of the things that I think this is one of the fundamental problems in our healthcare system is an enormous number of regulations are out there, all kinds of rules that affect patient care. And if we have some question about it, or we think, well, this is a rather stupid thing, or why don't you do it this way or that way, it's very difficult to communicate that to anyone. And so it's a little bit worrisome to imagine a healthcare system that is seemingly is going down the pike, where so much power is going to be centralized in a very restricted number of people, a very small group of people are going to be right at the top of the food chain and be able to propagate different kinds of regulations that are going to affect healthcare in this part of the country and everywhere. I mean, and it would be a good thing to be able to respond to regulations that we think are inappropriate. And I don't know, you have any comments about how you do that? It'd be very tough, wouldn't it?
Well, we're going to, unfortunately, and I think you're talking about what are physicians unsure about and what are they worried about. We also know that what's coming down as part of this is bundled payments. We're going to be moving a bit towards the Canadian healthcare system, where we described earlier, accountable care organizations are going to be responsible for a large bunch of patients, which are then going to be given a certain amount of money for certain things to take care of them within a thing. And if you don't work within that budget, then you're going to have discussions amongst everybody involved about who gets cut from what money.
Well, now let's discuss, maybe we could just say.
So that unsurety is going to lead to going back and argument with the people who are going to measure and tell you.
Well, yes, you mentioned the word bundle payments. Why don't you just say for our audience what a bundle payment is? What is that exactly?
Bundled payments will be where they're going to take we're not really sure, they're going to take large amounts of money and say this accountable care organization with this group of patients should be able to care for that group of patients over the next period of time, whether it's a quarter or a year or 3 months, or a half a year, and say, here is the amount of money you need to take care of that group of patients.
And who gets the money? Presumably we have providers, hospitals, nurses, drug companies.
We're not sure.
Who's going to,
the presumptive person right now, or the presumptive entity, is the hospital.
So they'll get the money and decide how to divvy it up?
Because right now they have the pre-existing financial relationships with the federal government for moving money around.
Yes. So this sounds a little interesting, doesn't it? So
worrisome.
Well, it's going to be a big problem about some of the tensions that could arise. One thing that concerns me is that the accountants may blunder in deciding the appropriate amount of money that would be there. And I think the Canadian system has been is if you exhaust the money, you're just out of luck. If you're the last person to come in that needs a hip replacement, it's just too bad. The money's gone. I mean,
wait for the next quarter.
So that might be an issue.
That might be an issue we're facing, which essentially creates a system of denial of care but without somebody, they want us to be the deniers.
Yes.
And I think that's going to be a role we're going to be very uncomfortable in.
Now, let me get this straight, Eddie. You mean the politicians don't want to be the people at the bedside of the sick patient? We don't want to have someone brought into Washington, from Washington, to explain to the aggrieved family why, unfortunately, we can't do the hip replacement or can't give the care we needed. It won't be the politicians that are sitting at bedside of the bed. Is that a fair statement?
The politicians state unequivocally that based upon the money flow and the population growth, that Medicare is going to fail unless they come up with a way to reduce the flow of money. And so they're trying to figure out a way to reduce the flow of money while also not bearing responsibility for it at the front.
Yes. Now, Eddie, maybe I can just beat the drum and say one of the things that's good that's happened in the American healthcare system. I won't belabor all the slanderous accusations that appeared about how terrible healthcare was in the country and how horrible things are here, contrasted to some Central European paradise like Poland in 1950, how great it was there, how wonderful it is in France.
Don't forget that the French have the world's best. The World Health Organization says France has the best.
I'm sure. Actually, we have all these loaded statistics that have been used in to me, a very non-truthful way. But one of the things that has happened is our healthcare system has enormously increased the life expectancy of Americans. So it's incredible how long people are living, and they're living healthy, useful lives. And this is a tribute to what's gone on in our country for a long time. It's tremendous. But one thing that you mentioned is that the tremendous increase in longevity, people living vigorous lives, lots and lots of people are going to be dependent upon Medicare, with the government not intending for them to live that long. So one of the things that disturbs politicians was when this benefit was passed out to American people. Let me be slightly cynical with the idea that they might have been thinking it would secure votes for them. We're going to give you all these benefits. However, unfortunately, the healthcare system is letting everyone live so long that they're trying to renege on the benefits. And so that's the system we're in right now. What are we going to do about that?
And they don't want to accept responsibility.
And so we have a very difficult issue here about our older citizens. And we chatted a little bit about this, about doctor shortages. We have these millions of people that are in the hopper. They're living longer. We have lots of new people coming into the system. And we don't have enough physicians to look after them.
Absolutely.
That's a big problem, and no one seems to have considered it. Is that a fair statement?
Well, they're certainly not talking about it, and it's not a planning issue. The pipeline for generating physicians in our country has got a choke point, and that choke point is the ability to train residents in the hospitals, because to become a physician in practice, you not only have to go to graduate school, which is medical school, but then you have to undergo your formal training, and that is done in a supervised manner in teaching hospitals. Those spots are actually paid for by the federal government, and they've got a chokehold on that, and there's only a certain amount of training spots.
Yes. Now, it's unfortunate tonight, Eddie, we don't have any representative of the federal government here, so we're just beating these guys up a lot. I apologize if there are any federal people watching us tonight. But it is a little stupid what's happened with the training of doctors in the country. My understanding was the Balanced Budget Act, if I can get this straight, in 1997, limited the number of training spots because the idea du jour at that time was that we didn't need a lot of doctors, and doctors were going to drive expenses up, and the best thing to do would be to not have too many of them around.
Don't forget, managed care was going to fix
That's right. So we had a gatekeeper, and you just would have you would never see a doctor, and you wouldn't need one. If you saw one anyway, it would be too expensive. So the feds really stopped the production of doctors. And if you look at the medical school enrollment, the number of people are out, it's been running at about 15,000 a year, maybe it's up a little bit, and the number of people actually entering residency programs is a very, very small number. The other thing that was nutty about this was that the training spots were preponderantly in the northeastern part of the country, or maybe on the West Coast. States like Georgia didn't have enough, they don't have a number of training programs to keep up with their population. So now Georgia has almost 10 million people in it. There's been a huge increase in our population. Our training spots are frozen, referable to this 1997 Act. And another thing that's a little nutty, I hope there are no bureaucrats watching, is with this enormous amount of change in the healthcare system, with billions of dollars and all kinds of structural changes, there hasn't been any substantial training or any substantial change in the amount of funds available to train doctors. So we have this terrible situation, don't we? We have an extraordinary number of regulations coming down the pike. We have all of these doctors that are at least nervous, or they're timorous, or they don't like the deal. They might not be good players for these for the federal regulations that are there. We have this train wreck that's about to happen. Is that a fair statement? Do you envision a train wreck?
I followed, your logic is quite good, and it's a very fair statement. And to take that one step further, understand that the amount of money that has to be spent by the individual to get their medical education, the government does not pay for medical education at the baseline
Yes.
for medical school. There is a tremendous debt problem
Yes.
for medical
Yes.
students. And interestingly enough, at the same time, we have some rather liberal immigration policies that allow physicians to come into this country, go through their training, and then once they get their training, be able to be practicing physicians in this country if they meet the visa and regulation rules. And those doctors often come in with no debt because they
Yes.
have been trained in their other countries, whether by their military or by their
Yes.
country themselves. So actually going forward, I'm afraid that we might have become a net exporter of physicians,
Yes.
of American trained physicians that ultimately might have to be looking for outside employment outside this country.
Well, Eddie, I'll just say one thing that's slightly positive about this. It's been my experience when these train wrecks are about to happen, someone steps forward and then turns off the motor. So, I mean, something,
It's the brake. It's the brake.
We're going to do something here. But I think it's important for
You think the break might be the election process?
Well, I think the American people just need to be watching this whole set of circumstances. And I think it's important for physicians, and such as yourself, to make comments about it. I mean, I think the tendency is for many reasons, just try and look after our patients on a micro basis, try and do a good job. And the macro events that are impacting the world often are in the hands of the politicians. And I think it's important to make comments about what we think is right or wrong about this. Not everything the government does is wrong. They do a lot of good things, but it's very worrisome what could happen quite soon to the healthcare system.
And I think as president of a medical society, as a practicing physician, we're really concerned about the patients. We want to be able to provide care for our patients. And
Yes.
going forward, that is really a worrisome context for lack of physicians.
Yes.
The number of physicians that might choose to do something else.
Yes.
I mean, that is always an option.
Now, Eddie, here's one thing that concerns me a little bit. One thing I've observed is that we're getting sort of I don't know what the right way to phrase this is, but because of the economic structure of the country, of the healthcare system, many doctors are no longer seeing Medicaid patients. They're not seeing TRICARE patients. There are a lot of TRICARE patients around, and Medicare patients. And the system, that may be something that becomes even more of a problem as the year goes, as we go into 2013, 2014, 2015. Any comments about that? I mean, what's going to happen if physicians say, economically, I can't do this? And also I guess the difficulty in keeping track of all these government regulations just means that physicians might want to say, I'd just rather have a restricted practice. Or any comments about that?
Well, I think you're going to see a two-tiered system. I mean, that's what you're seeing, that's the first step in the evolution of a two-tier system.
Yes.
Where there's going to be a group of physicians that care for a base group of patients, and then the other physicians who are entrepreneurial, that
Yes.
have figured out how to go outside the system,
Right.
will be able to exist. There is examples of that in areas around the country, in Florida and places like that, where they're, the concierge medical services.
Yes. Well, it could be a very difficult set of circumstances, could it not? As to where people get their health care, what the rules and regulations are that impact that. And no one can say what's going to occur.
Well, an example of a worrisome rule, it is against the law right now for you as a concerned physician and with your experience and education to start your own specialty hospital.
Yes.
It used to be doctors could have a specialty hospital, try to deliver excellent care. I've seen eye specialty hospitals,
right.
orthopedic specialty hospitals.
Right.
Well, by current legislation, that's against the law.
Yes.
You and I cannot go out and be a specialist in a hospital.
Right.
So, the regulations are forcing us into a very small area, and of which there might be some, I'll say, benign rebellion. There won't be active rebellion, I don't think, but there'll be benign rebellion by physicians seeking other means of making money.
Yes.
So.
Okay, well, thank you. So this seems to have slipped. That's good. I'll fix it. As we close, Eddie, one of the issues that's out there is the situation in Massachusetts. Maybe you can make a comment about this. This is the first it has the highest expenses of any state in the country. Healthcare costs more than anywhere else in the country in Massachusetts. This is where, if you want to say, our presidential candidate, Governor Romney, put a pretty liberal arrangement together. And right now it appears that there's not enough money to make the system work, and they're attempting to ration health care, to use that phrase. The money that's available to treat things is not working.
Well, aren't we glad that they did that and found out that it didn't work, and they did it on a small scale, so now we know that on a large scale it probably won't work, and that we can now have an accurate predictor. I mean, in medicine, that's how we learn.
Yes.
I mean, we have an environment, we look at it and say, you know what, that treatment didn't work very well. Maybe we should try something else.
Well, Eddie, it's been great to have you here. We'll have you back again. Keep up the good work. Keep talking and keep trying to make things better.
Well, we enjoy your time.
Thanks a lot. Thanks to be with us.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.